Thanks, Marilyn. Thanks to FCCM for the opportunity to be here. Was asked to talk about maintaining preparedness at the national level, which I think is sort of an interesting concept because I think you could have a very cogent argument as to whether we've actually achieved preparedness at any national level and are in the phase to maintain it, or if we're really talking about arriving at a destination that we'll probably never get to, but sort of continuously strive towards. I don't have any financial conflicts of interest to disclose. I am part of a project that receives federal funding from the Assistant Secretary for Preparedness and Response in CDC called the National Ebola Training and Education Center, which is an effort geared towards facilitating healthcare and public health preparedness for Ebola and other special pathogens. So, for example, our novel coronavirus, COVID-19. I think the previous speakers have already covered this nicely. These are just some photographic examples from recent events within the last couple years that many of our colleagues have been involved with in terms of preparedness and response to events. And I think we can expect these events to continue to rise in frequency, unfortunately. So there's clearly, this is data from The Economist, but there's clearly a rise in the frequency of severe weather events, and I think many of us have experienced some of these. You know, Houston flooding recently, the major hurricanes in the Caribbean. And I think we can expect those to continue in frequency. You can see the slope of this curve is sort of rising nicely and continuously. This graph terminates in 2016. Similarly, the rise in frequency of human infectious disease outbreaks is climbing. And this is different types of pathogens here. And I don't want to belabor the point, whether it's vector-borne or fungal or zoonoses, but I think we may be in the early stages of the next major outbreak, depending on how the spread of COVID-19 moves from mainland China to the rest of the world. But we can expect that it's probably a matter of when and not if we'll be in the throes of a major infectious disease outbreak. So as healthcare professionals and focused within the healthcare delivery system, I think it's helpful to think about disasters in sort of two types of, really three buckets. One is a sort of internal disaster, and you can think of that as something that just affects your local healthcare delivery, so your ability to deliver care. And that could be something like, power goes out and you're on backup power. It could be a cyber attack and you lose, we're all, I think, sensitive to cybercrime and ransomware and whether you lose access to your medical records. Or, a fire that affects the operating room, so forth. So you can think about that as a confined scope, but it definitely affects your ability to deliver care within your facility. You can also have external events that happen outside of your ability, where your infrastructure in your healthcare facility is preserved, your operating rooms are functional, your blood bank is functional, although you may be low on supply, so a mass casualty incident, flooding outside that. Or commonly you may see mixed disasters that affect both the infrastructure ability of your healthcare delivery system as well as the community around you. And so one example of that would be pandemics, right? Because pandemics do affect our community. We're likely to have healthcare workers become infected, not just through their work, but through the community. So you may have diminished staff availability in those settings, as well as natural disasters that have both a combination of damage to the community as well as damage to the facility. And the example that Chet gave of Hurricane Katrina is, I think, a really poignant example of that, where you're talking about a mixed disaster. It was a disaster both obviously in New Orleans as a whole, but also within the individual healthcare systems there. And so when we're thinking about our ability to prepare for disasters, we have to think about what type of event are we thinking about, and what are the different elements that would go into being prepared for that. So Lee Biddison and Louis Rubinson, who I think many of in the audience probably know, wrote a really lovely paper in 2011 that was published in Critical Care Medicine, sort of defining what preparedness looks like, or what does it look like to be prepared. And I put air quotes around it on purpose from that. And they were specifically talking about ICUs, but I think you can generalize this to other settings as well. So you have to understand what the hazards are. We can't prepare for everything, right? So you can't prepare for the zombie apocalypse, because quite honestly, the zombie apocalypse probably isn't that likely to happen. But you should start thinking about what are the events that my community and my institution and my ICU or my emergency department are most at risk for. So you need to understand where your risk lies. And then after you understand where your risk lies, potentially start thinking about what are your vulnerabilities to continuing to deliver care based on those risks. Use those steps then to start preparing a written plan about what you would look like. Obviously, most written plans are going to focus on the S's, right? Space, staff, stuff, or supplies. You're going to talk, as we heard about from Chad already, something about allocations of resources under conditions of either relative or absolute scarcity. Think about what you would do if you had to try to evacuate, if that would be an option or not. And clearly thinking about how will you communicate with people. And I would add as well that I think is an emerging area that we need to focus a lot more on is how will we get information in these settings to inform others of our response and to help folks who may not yet be affected begin to prepare more accurately. So for anybody in the room that does QI will recognize this. This looks a lot like any quality improvement cycle. You can substitute, PDSA here if you wanted to, but essentially it's a quality improvement engagement where preparedness is one central component of emergency management, but it happens in a continuous cycle of mitigating, preparing, responding, recovery, and using those processes iteratively to improve going forward. So one example of a risk assessment, and this one is actually quite dated because I think the undertaking of doing this on a community level is quite extensive. This is from New York City, and this is from the New York City Department of Public Health or Department of Health and Mental Hygiene from 2013. And what they did was they did a comprehensive risk assessment of the New York City's risks. And then they plotted it by the likelihood of the event happening versus the impact on New York City. And you can see where everything lies here. We have pandemic influenza, which would have a critical impact. And they put that probability in 2013 somewhere between a remote to occasional probability of occurrence. An improvised explosive device had both sort of a mid-level impact and a mid-level probability. Flooding and coastal storm were both in the higher probabilities. And I think this is a really good service to the community for a place like New York City to do to help us at the local level think about what we're most likely to face and how we can begin to prepare for that. You can also take this down to the facility level or the healthcare system level. And this is a tool that's freely available. This is the Kaiser tool for hazard vulnerability analysis. And this is the example of one of the ones that we did as part of the New York City public hospital system, looking at what we thought our hospital-based risk was. And again, it goes into the same concepts go into this. What's the probability of an event and what's the impact? And the Kaiser tool breaks it down by what the impact is on humans, property, business. And then it helps you prioritize what the risk is and how you would respond for that. So our hazard vulnerability analysis in the New York City system, this is from a couple years ago now, had the three highest ones being explosion, inclement weather, an infectious disease outbreak, and an IT system outage from that. And then we categorized them by first priority of risk score there. So once you've sort of started with this concept of where do my risks lie, your best step in preparedness would be to try and fix those underlying risks, right? It's not rocket science. So you would try and mitigate what those underlying risks might be. So if you institution says we're at real vulnerability for flooding, we live in a low-lying area, where coastal storms are increasing in frequency, what can we do to mitigate the risk of flooding there? And whether that be flood barriers, if you're in an earthquake zone, seismic retrofitting, and clearly even public health campaigns like influenza vaccination are a great mitigation strategy to reduce the impact of an event on an organization. And again, this is all occurring as part of a continuous cycle. You're also going to prepare for the event beyond what you can mitigate from that. And that's a continuous process of planning, organizing, training staff, making sure equipment is operational and present, exercising or testing our ability to respond to simulated events, using evaluation tools, and basically writing improvement plans that we then follow up on to reduce our risk going forward. So you should be developing these plans, and then we need to test them. And so we need to test our capability through drills, simulations, and exercises. I want to bring your attention to one effort that's going on at the federal level. I'm not involved with this, but the Assistant Secretary for Preparedness and Response has funded 4 regional demonstration projects, which I think is a great example of improving preparedness at the national level. So some of you may have heard of these regional disaster health response system pilot projects. There are 4 of them. There are 2 adult-focused projects, and those are focused in the University of Nebraska and at Mass General Hospital, and 2 pediatric projects, one focused in Cincinnati and the other in San Francisco. And it's meant to bring together disparate types of resources, because I think a lot of our preparedness efforts typically happen in a more siloed fashion. So this is all about improving organization and coordination for a variety of threats. So whether it be chemical, biologic, radiologic, nuclear, mass casualty incidents, trauma, you name it. It's trying to bring all of these stakeholders and resources to the table to think about how can we work better as a larger scale community to respond to an intervention. So improving situational awareness as well, identifying and developing highly specialized clinical capabilities, and this is particularly focused around things like burn or radiation exposure. And increasing the healthcare coalition model to do that, because the healthcare coalition does span the continuity of care. It's not just about the emergency department, it's not just about the ICU, it's also about long-term care, nursing homes, so the entire healthcare delivery system writ large, which is all would be effective in a large-scale event. As part of our preparedness efforts, we also want to think, as I mentioned earlier, about what our research preparedness looks like. And there are a lot of ongoing efforts to build our capacity for research infrastructure to ensure we learn from events. And I'm personally most familiar with the research capability or infrastructure building around preparedness for biologic events, but these are multinational efforts. The European Union has an effort, Australia has the APRISE group, which you may be aware of, and within the US, within the FCCM, we have Discovery Prep, or the Resilience Intelligence Network, which was sort of founded and spearheaded by Dr. Perrin Cobb, with the NETEC Special Pathogens Research Network, and the National Institute of Environmental Health is forming a disaster research response, or DR2, planning project to ensure that we are building the research infrastructure to be able to make sure that when an event happens, that we can learn as much as we can and that we can disseminate that information effectively and in a timely fashion. There's clearly this needs to be part of preparedness efforts, because once an event is happening, it's way too late to build a system to collect the data from that and to report it and disseminate it in a timely fashion. I think the keys to all of this, and this is something we'll come back to, is communication, collaboration, and coordination. And quite honestly, it does need funding. That response, I think we heard from Antonio and from Chet already about some of the principles of response. We're mobilizing to an external or internal event. We're using those plans that we made. The plans that we make are clearly going to be resource specific. So if I'm preparing in a highly resourced environment, I'm preparing for a situation in a disaster where I become resource limited. If I'm resource limited to start, like the example Antonio gave in Mozambique, my ability to plan for that surge capacity and implement crisis standards of care is probably going to be limited, because functionally I'm already operating in near that environment. We're going to use an incident command system, obviously, to respond to this, and then we're going to hopefully learn from this in a continuous and iterative process and disseminate that data. Recovery is clearly the most protracted state of any event. From that, it's the hardest to return an affected area to its previous state, and many places that have experienced events are still recovering. I think if you ask residents of New Orleans, where Katrina was in 2005, I think they would say they are still recovering from that event. And the recovery efforts sort of shift focus from immediate needs to rebuilding, to reemployment, to repairing existing infrastructure and reopening of essential services. And Chet mentioned earlier some of the mental health considerations that I think are a particularly prominent component of recovery. If we are preparing effectively, if we engage in these processes, which do take time, they take effort, and they do take some diligence to paying attention to it. And it's hard to do in a world of competing priorities, right? We all have immediate problems. And so it's hard to sort of sit down and find the time and find the engagement for people to go down these sort of what-if pathways. But the goal is, if we do this and do it effectively, we will be in more resilient organizations. And so we'll be more prepared to absorb and recover from and adapt to adverse events that functionally are inevitable. The scale may vary, but we will all be in some sort of adverse event at some point in our professional careers. And this is a really nice document I would just call your attention to, that it goes through many pages of that, but it defines some characteristics, much like Lee Biddison and Lou Rubinson define some characteristics of what prepared ICUs look like. They define some characteristics of what resilient communities look like. And I think these will sound thematically similar to some of what we've covered. So resilient communities have assessed risks and have a plan. They work together. They anticipate change, they have stakeholder engagement, they have clear goals, and I think this, probably the last bullet point, probably should be up at the front when I remake this slide, is have leaders who commit to improvement and accountability in a process. If you take one thing home from this today, I hope you'll go back to your home institutions and either do this yourself if you haven't done this, or encourage the people that you work with to do this as well, as to make a personal or family disaster plan. From that, we mentioned the zombie apocalypse earlier. If you actually Google CDC zombie apocalypse, it takes you to the personal disaster planning page on the CDC website from that. But if you don't have a plan, we're less likely to be able to respond effectively. So I won't be able to concentrate on work, stay at work, or really fulfill my job if I'm worried about, I don't have a plan for my kids or my family or my dogs. What would I do in those situations? And so there are some great tools out there to help people develop a personal plan for what that would look like. So just to summarize, I think the keys to maintaining preparedness are very, very simple. It's about communication, collaboration, coordination, building a plan, exercising or testing it, and refining that plan. I put some resources up here on the next couple slides right before I finish up that I think, if you want more information, are great places to start from that. The CHESS statement is terrific. There's a ESICM, or European Society of Intensive Care Medicine, about pandemic planning, which is very useful. Some of the local or jurisdictional public health departments have done some terrific work around this. Minnesota is a great example of that. WHO has resources, and on the FCCM website, there's a great book, ebook that's called Preparing Your ICU for Disaster Response.